This week, I wanted to talk about something that made headlines and seemed to get everybody talking. A couple of weeks ago, in case you missed it, tennis legend Serena Williams said she used a GLP-1 medication, a weight loss drug, to get her weight back on track after her second pregnancy.
Because I literally tried everything. I mean, running, walking, biking, stair climber, like you name it, I did it. I mean, even down to trying to play professional sport. So it was something that I feel like even I felt like, okay, I don't want to do this because it is a shortcut or it is like, a quick way out, but it actually isn't. And there's something that I feel personally, like I said, that my body was missing, in particular after having two kids. I wasn't able to be at a weight that was healthy for me.
And she said she used a GLP-1 drug along with her regular routine and lost more than 31 pounds. She also said she wanted to remove the stigma since so many people use these drugs but don't admit to it. So I put this to you as a question across my Instagram accounts. And I ran a quick poll asking if celebrity admissions like Serena's help reduce stigma or increase pressure to use weight loss drugs. 32% of you felt it reduced stigma, but 68% said it increased pressure on weight loss drugs, or you felt that it did. Now, Serena also became an ambassador for the company that helped her, and that prompted questions about transparency because her husband is an investor in the company and serves on its board. And some of you asked questions about that, which are valid, but that's a separate conversation because today I wanted to do a simple explainer about GLP-1s themselves, especially since there's so much news and noise around them. In a moment, I'll talk to a physician who specializes in obesity medicine to clear up some of that noise and to ask her some of the questions you sent me. But first, I want to show you how big this market is. Now, you probably know GLP-1 drugs by their brand names: Ozempic, Wegovy, Zepbound, Mounjaro. Now, there are some differences between a couple of them, but they're all part of a class of drugs used for weight loss. Now, globally, analysts see massive growth ahead. According to IQVIA, which is a healthcare research group, global spending on obesity drugs was more than $30 billion in 2024, but that's up from $3 billion in 2020. So that's more than 10 times in 4 years. By 2034, spending could reach $130 billion, growing at an average of 13 to 15% a year. Eli Lilly and Novo Nordisk, the two leading makers of weight loss drugs, say the US remains the biggest market for now, but both are rapidly expanding into fast-growing international regions, especially Asia Pacific and parts of Latin America. At the same time, China and other markets are working on generic versions of these drugs, which could mean more access to more people. But I don't want to get bogged down in too many numbers in this video. Let's just get into the nitty-gritty health questions surrounding these drugs. What are the pros? What are the cons? Here with me is Dr. Resham Uttamchandani, a primary care physician who specializes in obesity medicine.
You're joining me from California, so thank you for that. Or we call you Dr. U.
Yes. Well, thanks for having me.
So, Resham, what exactly is obesity medicine? And tell me your journey on how you got into this field.
I'm primary care physician. I focus on nutrition, metabolic health, longevity, and hormones. And the way I got into this field is because I felt like I was failing patients. I was in the traditional medical model, and a lot of my patients would come to me. We had really short appointment times, whether it was 15 to 20 minutes, and they would bring up weight loss. And they would, suggest medications. And to be fair, I didn't know enough about the medications. What I was taught in medical school, and for my boards was that these medications have a lot of side effects, and the ones that were on the market at the time were just, too complicated and required a lot of monitoring, and we just didn't know enough. And I wanted to seek additional training to understand, the biochemistry and the physiology of obesity medicine as it has now been characterized as a chronic disease that needs to be addressed from various aspects. So we're talking about, lifestyle factors, we're talking about environmental factors, we're talking about genetics. And so you need to look at it from that lens. It's not just discipline and willpower, it's greater than that.
And so what does that mean practically on what types of things you do?
So I do advanced lab testing. I do body compositions. I get a very, very detailed history of my patients. So, for instance, I get their background. I understand what their medical conditions are. I get a really good family history because a lot of times it runs in the family for several generations. So once I get the entire background of my patient, I then go through different options, whether that's just lifestyle, diet changes, strength training, resistance training, or, do they qualify for medical management?
Let's start with the definition. So, we see this phrase GLP-1s, we see GLP-1 receptor agonists. Are they the same thing? What exactly do they mean?
GLP-1 is a natural hormone that's produced in your body after you eat specific nutrients like carbohydrates and fats. And it's produced in the intestines. It's again, a natural hormone that triggers the pancreas to release insulin. It also helps your body slow gastric emptying. And it increases your brain to feel like, it tells your brain to feel like you are full and that you are not hungry. The drug is a GLP agonist. That's what they're referred to as. So semaglutide is a GLP-1 agonist. So what it does is it mimics or enhances the effects of the GLP-1 hormone in our body. And so the semaglutide has all these benefits that we talked about that GLP-1 agonists do. But tirzepatide is a dual agonist. So it's GLP-1 and GIP. So GIP is also produced in the intestines and it works very similarly, but also targets different areas in the body. So with this dual agonist, what we're seeing is more fat loss.
So basically, we might be talking about all different kinds of acronyms, but they're all under this weight loss class of drugs. And the one that's suited for you is something I'm assuming you'll have to figure out with your doctor and because of your conditions.
Yes. And there are newer drugs coming out with more, not just a dual agonist, but, targeting three different. So it's, GIP, GLP, and glucagon now. So that's something that you should be looking out for. And I think that's also going to change the landscape of managing obesity.
So when these drugs are used for certain medical conditions like type 2 diabetes, what's happening with those people? Are they not producing GLP-1s? What's happening with them?
So with these patients, what's happening is that they have become insulin resistant. So for instance, these patients, they eat carbohydrates and fats, and this is triggering GLP-1 to be released from the intestines. And GLP-1 is supposed to trigger the pancreas to release insulin. To work insulin's magic of decreasing glucose in your body, it's not being done because the receptors are not responding to that insulin that's floating around in the body. So you're just having a lot of sugar in your blood cells and you're having higher levels of insulin.
And when that extra sugar doesn't get used properly, it gets stored as fat.
So it's frustrating because these patients are gaining weight and they have no way to lower their sugar because they've become insulin resistant.
Who actually qualifies to use these drugs?
So these drugs are qualified for patients that have a type 2 diabetes or a BMI of 30 and above, or who have a BMI of 27 and above with a comorbid condition related to obesity. So whether that's hypertension, so high blood pressure, high cholesterol, sleep apnea, fatty liver disease, all of these conditions are related to obesity. What I want to also address is that the BMI doesn't give the full picture.
Mhm.
That's what I'm learning about in my practice. It's just one part of the entire story. And I think that it is really important that we talk about body compositions because, a patient could have, and I've seen it personally, where they have a high BMI, but they have a lot of muscle and they're just, because of their height and their weight and the ratio, it just puts them in the obesity category. And technically,
Mhm.
they would qualify for the medication. And then I've also seen patients who are considered skinny fat, where they look great,
Mhm.
but when you do their body composition, they're in a range that's called like sarcopenic obesity, meaning, above 30% body fat. And you can't see that at face value.
So I've got one person who messaged me that he has been told by two doctors he qualifies because he's technically obese. But when he's tried to get the drugs, his insurance company won't approve it. So what would he need to do? Like, how does he go forward with something like that?
So I've seen this a lot in my practice because I do accept insurance at one of the companies I'm working for. And uh, documentation is key. The advice I have for these patients is to collect enough data on their health history. I'm talking about when did the weight gain start? What have they tried? What diets have they tried? What are their lab values? Have they tried other medications in the past? What's their family history? All of these paints a picture for the insurance company to understand that this patient, should qualify for the drug. They're not just going to base it off BMI. They want to see that the patient has tried other methods for weight loss.
It raises one of the questions that it's a rich person's drug because if you have the money, you can just pay for it and do it, which is why we're seeing so many people using it just for weight loss purposes as opposed to medical reasons, right? So how do you go around that? Should there be some kind of should there be more restrictions on how easily people can access that just by paying for these kinds of drugs?
Yeah, that's a great question. And the answer I have is that, again, we don't know everyone's health history, and I am my patient's biggest advocate. So I need to make sure that I understand the the patient's medical history. And we don't know whether, someone has a lower socioeconomic status or not if they qualify for the medication because I don't know their health history. And these patients who might not be able to afford the medication out of pocket, I feel like they need to find a doctor that's going to work with them to get the right history, to work with the
Mhm.
insurance companies, to get this medication at a price that is affordable for them.
People around the world have been messaging me. So I think in different countries, they'll have to go through different procedures to find the right doctor. This specific person who asked me is in the US. So just asking for him or other people like him, is there an easy way or is there a place that they can go to or he can go to find the right doctors for this?
So there is a American Board of Obesity
Mhm.
Medicine. That's a great website to find doctors that have the board certification because they will understand a lot about how the medication works and how to work maybe with insurance companies. I think that's one
Okay.
place to start.
Okay. Resham, is who doesn't qualify for something like this? Like, that's the hard part, isn't it? If people can pay out of pocket and just get the drugs, are there people who shouldn't be taking this at all?
Yes, there are contraindications for this medication. So, number one, patients that have a family or personal history of medullary thyroid carcinoma cancer. Another one is multiple endocrine neoplasia, pancreatitis, obviously pregnancy, breastfeeding, and someone that maybe has a hypersensitivity or an allergic reaction to it.
Okay, so let's talk about the side effects. It's something that comes up again and again. The number of people who message me and we're like, let's not forget about the side effects. Let's not forget about the side effects. So, side effects. We hear about the nausea a lot. So tell us what the side effects are, Risham.
Yes, the biggest one is nausea. A lot of our patients complain about the nausea, and it's usually dose dependent. So it's usually when we start the medication and when we ramp up the medication, that's when you experience the most nausea. And a lot of times it dissipates. Another one we see is diarrhea, constipation, abdominal pain, headaches, fatigue, a lump in your throat or your neck area, you're having trouble swallowing, persistent hoarseness. But more than that, we also worry about the bigger complications, which are small bowel obstruction. So that has to do with, the slowing of the gastric emptying, because as, your food becomes more sluggish, it can get stuck in the bowel. Another thing we worry about is, the thyroid cancer, which is why it is a, absolute contraindication for the medication. And because you can get dehydrated on the medication, it can sometimes lead to some kidney failure. So that is something we always monitor for as well.
So the importance is basically that you have to be very closely talking to your doctor about all of this. So I'm assuming if you have a doctor who's not monitoring all those things, that would be an alarm bell for anybody, right? So
Yes, yes, and that's why I do very close follow-ups with my patients. I think it is really important to hold their hand during this journey, because it is it's scary when you experience these symptoms, and you because you're on social media, you're seeing that everyone else is experiencing these symptoms, so you might mitigate the actual effects of them or not tell your doctor how bad it is.
I think again, because obviously you're speaking as a doctor who is monitoring your patients and monitoring what their side effects are and things like that. My question is for people who aren't going with a doctor, who can just buy these drugs off the market, and when they hear things like, "Oh, I'm going to lose more weight with this drug versus that drug," what should they be looking out for?
That's a great question, because it is becoming like the wild, wild west out there. And I think that is, there are a few questions you need to keep in mind. What are you taking the medication for? What condition, diagnosis, or health goal are you taking the medication for? Do you understand the side effect profile? Are you understanding that, depending on the reason you're taking it for, that this could be a lifelong situation, or are you just taking it to lose a few pounds? Do not self-diagnose and do not self-administer watching videos online or talking to friends about the dosages, because at each dose there can be specific complications, and it depends on each patient and their physiology of how they react.
One of the people who messaged me, this registered dietitian, she said that she's noticed this weight loss is so rapid sometimes that people are losing muscle as well, which is, if they gain that back, that's not going to be cool, obviously, because their body composition is changing. Can you tell us more about that? Is that what happens?
So yes, it is definitely a fact. When you are losing, weight by any means, you're going to lose fat and muscle. The way that we counsel our patients before they start this medication, they need to eat a high protein diet. But more importantly than just the diet is strength or resistance training. The reason behind muscle is because it's a fat burning organ. It's literally helping you control your blood glucose levels. So the goal for my patients is to get them to strength train, eat a high protein diet to mitigate some of that effect of the muscle loss, as well as to create a lifestyle that when they get off the medication, they're already building these healthy habits to keep that weight off.
So when you stop these drugs, will you start gaining the weight back?
It depends on the reason for obesity or the weight gain to begin with. So, for instance, if it is a patient that has a genetic mutation, they're going to be on this medication lifelong. If this patient is just, in her menopause, phase of life, and they're losing estrogen and they're gaining a lot of visceral abdominal fat, and, they're losing some lean muscle, and they get on this medication to help, combat some of that, visceral fat, I think that there is a possibility that they can get off the medication. Again, it's just about, building the muscle, eating protein, creating healthy habits. But, like I said, obesity is a multifactorial disease. And so we have to understand that it's not just genetics or it's not just hormones. We have environmental factors and a lot of things working against us, as a society. So we have to also keep that in mind.
How long can people stay on this medication?
Some patients are on it for life.
Is that safe?
It is safe because just like blood pressure or diabetes, These are chronic conditions that need to be treated. So just depending on the reason, but I have successfully gotten several patients off the medication, and yes, they did have some weight gain after because again, you're changing the physiology, but you have to have those lifestyle factors in place to make sure that the weight doesn't come back because aging is still going to happen. You're still going to be exposed to your environmental factors. You're still going to have, the cravings will come back because the GLP has helped you feel fuller longer and helped you decrease your appetite, and all of that's gone. So the food noise can come back for a lot of my patients. It just depends on what we're treating it for. It will depend on, how long we keep the medication going for these patients.
So, do we know the long-term effects?
That's a great question. So the first GLP that was ever released was in 2005, and it was exenatide. It was a twice a day daily injection, and that has evolved to, now a once a week injection. So I think that the landscape is changing, and I think that this is just the beginning, but more studies need to be done to figure out the long-term side effects.
But the drugs are changing, so that's still going to be, there's going to be, those 20 years is for a particular drug, right?
Yeah, so exactly. So like you said, as newer and newer medications come out, we need to do more, long-term studies to figure out and understand what are the long-term side effects. And we're just going with what we know, and we know that this medication can treat this chronic disease of obesity, and we're treating our patients, counseling them, and we are, taking it day by day and step by step and making sure that they're not experiencing side effects, or we're screening for, long-term complications such as cancer as well as pancreatitis. So I think we're doing what we can, because the alternative is that these patients suffer with the obesity, and obesity has long-term complications.
Is it scary that these changes are coming so fast when we're not even having time to see what the long-term effects are of each of these?
That's a great question. I think the risk benefit ratio, like I mentioned, I think it is really important to keep that in mind, because I would rather have my patients be at a normal BMI with taking the medication with less, possible side effects versus, living with obesity and having that risk with them, and, having that risk for cancer and other comorbid conditions with the obesity, whether it's sleep apnea, high blood pressure, high cholesterol, diabetes.
The other thing that, again, this registered dietitian, she said, while I recognize that there are medical reasons to use these drugs, people who have obesity or who have type 2 diabetes, and these drugs can help them. But she said there are also people who have behavioral issues that are not being tackled by these GLP-1s, right? So they might not being able to eat properly or not exercising, and those kinds of things that are not being fixed by these drugs, because those are behavioral issues that have to be tackled separately.
I really think it is important for patients to work with a licensed professional, what to look out for when they start the medication and they are just taking it, loving the weight loss, losing muscle, not doing body compositions, and it's wreaking havoc in their body, and they're not realizing it. They're just seeing what they're seeing, which is, their genes fit better and they feel better, but someone needs to be monitoring what's actually happening to their biology.
I just wanted to talk a little bit more about ethics and access. Is there a shortage of these drugs for the people who actually need it? Because there's so many people now who can afford to buy it, and they're just buying it for weight loss purposes.
No, the shortage is over. The medication is no longer in a shortage.
Do you think there should be any kind of regulation or any more regulation in the way these drugs are sold?
Yes, I think the FDA has been, cracking down on this, and the FDA has made some changes and have stricter control over the regulations now with these compounded pharmacies. So I think that's definitely in the works.
So when Serena made her announcement, there seemed to be a lot of conversation. And so I decided to do this unofficial poll on my Instagram. And I asked people whether they thought those celebrity admissions reduced the stigma about weight loss, or whether people felt that there was increased pressure. And according to this unofficial poll, it was about 32% of people felt that, Serena's announcement reduced the stigma, whereas 68% said they
felt that increased their pressure about weight loss. Although I did get lots of messages from people saying, it's a free world, people should do what they want. No judgment on Serena. People said celebs and health influencers should be honest about using them. So they admired her for coming out and being open about it. But then there was questions about whether it makes people feel like there's more pressure. What was your, how did you feel about that whole announcement?
When I first saw it, I was so uh, I was just happy that she was honest about her health journey. And she's the greatest athlete of all time, right, in her field. And she's doing everything right. She's working out, eating healthy. And it just makes you realize that, this disease is not, or just weight loss in general, is not always about discipline and willpower, because she
Mhm.
definitely has that. It's bigger than that. You have to keep in mind environmental factors, hormones at play. So whether that's perimenopause, as your estrogen drops, you are losing, muscle, and you're gaining fat in the midsection. And that's usually, one of my patients' biggest, complaints is they come to me saying, I'm doing everything right. I've been following the same diet for years. I'm working out like I used to, and my body's just changing. And so I think it's incredible that she's open about her journey, and we don't know what's really going on with her medical history. And as long as that weight loss is about 1 to 2 pounds per week, and it is safe, and she is metabolically healthy, hitting her health goals, then I think it's opening the conversation and actually decreasing the stigma.
So this has been a wealth of information, and thank you so, so much, Resham, for being with us and joining me from California. So thank you for that.
Of course, this was really fun. I'm glad that we were able to chat about this topic. And if anyone has any additional questions, please reach out. Happy to answer them.
You can contact Resham, also known as Dr. Yu, on her Instagram or website. I'll put the links in the YouTube description too. And if you like these videos and you find them helpful, you can like and subscribe on my YouTube channel. Thanks for watching.